Alright, so this video might take a minute, but I want to go through this because you need to see this from a cancer patient's point of view. And being a survivor, this is something that I would have much rather have had available to me. Not rather have had in the sense of not have taken any of the chemo or stuff like that, but now that we know this information, or since we've known this information, but it hasn't been furthered because politicians won't allow it to be given to doctors and put in their hands to be able to use and do their own studies, which is basically allowing doctors to practice medicine illegally, of course. So whenever you first get diagnosed with cancer, obviously you're gonna be looking at the cost, and the cost doesn't just include like the financial cost of the medical treatment, but the travel to go back and forth 5 days a week, the food that you have to eat while you're out, the new food that you have to eat, like non-canned foods and fresh vegetables and all that kind of stuff. All of that is included within the cost. Then you have the emotional cost. You have the external emotional cost, even outside of your friends, your family. All those people are having to deal with this type of situation. And people that have never dealt with cancer, this could be the first situation they've ever had to deal with, and it could be very impactful to their lives. Of course, it is, regardless of whether or not it's just the first time or, somebody else that you've known before that had cancer. Access to the necessary health care. So if people live out in the boondocks, as they say, or out in the country, having to come in and travel, and also not just that, but if they're wanting to get treatment at like MD Anderson, but they live in Iowa, having to figure that whole thing out, whether or not they're going to move or get a small apartment here or get some sort of benefit from like the American Cancer Society's Hope Lodge, those various type things that they can get through programs here, but that is still going to take time, and it's not a guarantee. So they're still going to be struggling to find out how they're going to get access to the healthcare by being in the area. And not only that, but access to the best healthcare, which would be at the best hospitals in the sense of cutting edge healthcare, like immunotherapy and proton radiation and just varying things like that that are being found at these better universities because they just have better funding. And it's mostly in the name, like MD Anderson, it's a big name, so they get big funding, so they're a good cancer hospital. UT Southwestern, that's where I go. I was at Parkland first, but they brought in a doctor that was number one brain surgeon. Christopher, I can't remember his last name. I never met the guy, but he's the one that came in and scooped the brain cancer out. They opened me up at Parkland, and he came in. Oh, Christopher Madden. And again, never met the dude, but he's the one that did it. So even me, they called in somebody to come to the hospital to do it, and instead of me being able to have access there naturally, if he couldn't come in, I would have had somebody else, and it would have worked out either way, I believe. But I just see that was obviously clearly I would include that as a benefit, having a well-renowned brain surgeon step in and do the actual job himself. Then you got to worry about the quantity of medicine you're taking in. The amount of medicine you take in can screw around with, you have all different types of side effects. Then it screws around with your physiology. So any of your chemical, which is like, you got anatomy, which is structure, and then you have physiology, which is systems. So systems and structures. So whenever you start taking medicine, varying systems within your body have to account for that medicine, and they will do varying things to either try and reject it or work with it, and that's whenever you start getting side effects. And some of these side effects have to be there, and you can't do anything about them if you're going to take the medicine, kind of like the chemotherapy. Like, if you want the chemotherapy, if you're going to go that route, you're going to kill the cancer cells through that manner, or through that method or protocol, then you're just going to have to deal with the side effects of that. So there's certain medications that those side effects can be just overcome for the sake of the long-term goal, but other ones can be switched out for other types of medications. And so the quantity of medication, like I take 4,000, I take 5,800 milligrams of anti-seizure medications. That's almost 6,000 milligrams. I don't know if any of y'all take medications, but just imagine you take maybe a 2 milligram or 10 milligram medication. I take 5,800 milligrams of medication a day. And so, like, if I could get off of this medication by transitioning over to CBD or a THC/CBD or any kind of terpene based, where they make a formulation, because most of the time it's not just CBD for these patients. They do have a little bit of THC in their regimen. Whenever they go over to meet neurologists in California or Colorado or wherever they're going, where politicians actually understand the science and care about the people that are bringing the science to them and showing them what would be called anecdotal but clearly in their face benefits, and yet every year they just dismiss it. And then you got the quality of life, which kind of comes back to the medicine. If depending upon what kind of medicine you have and the amount of medicine that you have to take, it's going to screw with or it could screw with your quality of life, in the sense of, sleeping more, being more lethargic. You end up putting weight on if you're on steroids. Just varying little things like that your quality of life will change if you start having all these medications put in you. So these are the first things that cancer patients have to think about whenever they're getting into this whole realm of treating their cancer. Now, below that you'll see the most optimal cancer treatment will, and this is a whole list, and if you were to sit down with an oncologist, whether a hematology oncologist or a radiology oncologist or a surgeon, a hematology oncologist is a chemo doctor, then you have the radiologist, and then you have the surgeon. Anyhow, if you were to sit down with them and you said, give me a list of all the things that would make the perfect cancer treatment, this would be the list. Go down the list. Anti-proliferative. So what it does is it stops cell cycle whenever it's going through. And whenever a cell divides, as it divides, they call it the cycle, of course. But you can have a cell cycle arrest, which is what's in the literature. So the anti-proliferative actions is cell cycle arrest. They're stopping the cells from duplicating, so the tumor stops growing. And then it prevents a blood supply. So anti-angiogenic. Angiogenesis is how your body creates new blood vessels to tissue so that the tissue can have access to all the nutrients that it needs. Like whenever you're a baby, you have to have angiogenesis. Whenever you're growing, you break something, you tear or you cut your finger, you have to have angiogenesis. But what happens is that the cancer will send out signals to make capillary type angiogenic small blood vessels around itself, and start feeding itself from a main, blood vessel, a main vein, which helps it to grow all the faster. That's angiogenesis is really where you can stop a tumor. That if you stop the angiogenesis, if you can stop the blood vessels from getting to the tumor will essentially, theoretically, just die off. But if it starts getting a blood supply, that's whenever it starts growing. If you want to look at anti-angiogenic foods, there's a website, I think it's Eat to Beat or Eat to Beat Cancer. There's also William Lee. If you type in William and then L-I, Lee, he's on YouTube, and he has a whole list of foods that are anti-angiogenic, so you can eat these types of foods while you're going through cancer treatment. Okay, next one, it induces cell death, so apoptosis. Apoptosis is a normal process that cells go through. Totally healthy cells as they age will go through apoptosis. Now, I could use we'll probably get to this in some other video, but the apoptosis of a cell is downstream of autophagy, in the sense that autophagy happens first, then that leads to apoptosis. Autophagy is the cell recycling itself. It's breaking down its organs. It's basically the process of killing itself so that you can get rid of it, and so like apoptosis is an induced cell death, but as it does that, it has to have autophagy happen to start breaking down so that it can be completely killed. And so this apoptosis is an induced cell death by a endogenous, specifically whenever we talk about how endogenous compounds work in the endocannabinoid system to treat cancer, we're talking about anandamide. And so anandamide will work within the body to induce apoptosis on cancer cells. But if we're talking about apoptosis and we're using external cannabinoids, exogenous cannabinoids, which is primarily phytocannabinoids, then it is also we're mimicking the same set of compounds when they act on the CB1 receptor to kill cancer cells. We're just mimicking that system to induce apoptosis onto the cancer cells, just like anandamide would do within our own body. So we're not hijacking, but we're boosting, or we're using the endocannabinoids, that's the system that is there, that is naturally our metastatic defender to keep tumors from metastasizing. And what they do is they do this anti-angiogenic and apoptosis effects. And so if we're able to also jump in there and do that, and we mimic that effect, then we can also treat cancer the same way that anandamide does in our endocannabinoid system, which would be a holistic treatment. Next one, prevent adhesion. So there's a gene called an ID1 gene. Sorry, part of the condition that I have messes sometimes with the back of my throat, and that's happening right now, actually. So I need to tilt my head down so I can talk. I don't know, it's like the flap in the back of your throat, and it relaxes. I'm gonna have to make another video, but I'm gonna keep this one anyway. So, alright, let me see if it's over. So there's an ID1 gene and a bunch of other genes that cancer cells will use, and different expressions that allow them to disperse, that allow them to, what is it called? Migrate. So migration comes, and that's what brings metastasis. But first, what happens is if you have a cancer cell that bursts off or breaks off, and it migrates around through the bloodstream, and it attaches itself, and it adheres to another tissue, it'll invade that tissue, and now you have lung cancer even though you started with colon cancer. Or you have liver cancer even though you started with, well, I don't know if pancreatic cancer would lead to liver. But anyway, you get the idea that if a tumor cell breaks off of a primary tumor into the bloodstream, because it has the angiogenic aspect to the tumor, it has blood vessels attached to it. So if tumor cells break off, they get into the blood vessels, and those blood vessels can carry those tumor cells anywhere around the body until they finally attach. If they attach, they invade, and if they invade, that's whenever you have a new tumor in a new location, and then that one has the same opportunity to break off and go out and invade some other part. And that's full-on metastasis. So whenever you see this adhesion, invasion, migration, metastasis, all of those words are used on cancer.gov. Every word that's used right here isn't my word. These are used on the studies that I'm quoting here on the rest of this presentation. So you can go to cancer.gov, type in cannabis up at the top. It'll give you it'll take you to, or maybe cannabinoids. It'll take you to a page where it has a list of different things, different types, different things that cannabis does. And if you click on it, it'll expand down. And one of them is the anti-tumor effects. And so if you just click on that one, it brings you down. And it has a long list of anti-tumor effects as far as the references. And there's over 34 references that they point to support their claim that cannabinoids, or cannabis at least, under the research or the search on the page, has anti-tumor effects. They're not hiding it, they're just not talking about it. And students really aren't learning it. Anyway, that's a whole other story. We'll talk about that in some other video. But also this whole protecting healthy cells, a lot of times they use the word that while protecting non-transformed cells or their non-transformed counterparts. So cannabinoids in the patent are neuroprotectants and antioxidants. And so they protect the cells that are around these cancer cells whenever we're treating them with cannabinoids or radiation. So whenever you go into surgery, you're oxidizing, you're exposing tissue to oxygen, and free radicals occur, damaging the tissue, hypoxia, all this different type of stuff that's listed in the patent that cannabinoids can treat. And so whenever we're talking about protecting healthy cells, we're talking about what they already have in the literature, in their own patent. So while you're going through all the treatment, while these things are happening, if you want to add cannabis-based treatment into your regimen, then it would also be protecting the healthy cells while you're getting treatment. And some people try and say that, and it might be this way with other types of newer treatment, like immunotherapy, some of that stuff. But as far as radiation and chemotherapy go, there's studies on this presentation I have, and so there'll be a video that I'll do on it, where radiation, it says that cannabinoids prime the radiation, or prime the glioma cells to receive radiation. And that just means like they make them more sensitive to the radiation that comes down. So you could even use less radiation and have the exact same effect if you apply cannabinoids. So you got cannabinoids protecting the healthy cells, boosting the radiation effects, which would let you get less radiation damage, and and the same thing essentially with chemotherapy. So it protects the cells in your body. Cannabinoids selectively target transformed cells. That's, I guess, the best way to say it. And so the ones around it, like CBD, is a very well tissue protectant, and it specifically protects glioma cells and varying other types of cells within the body, for sure. Without CB1 receptors and activation of them by our body naturally, we wouldn't be able to overcome any kind of stressors as far as physiologically, and really wouldn't be able to walk, breathe, or anything, because without an endocannabinoid system, you can't have the other systems function right. It's the regulator of regulators is what I would call it. Okay, and this last one here, inhibition of tumorigenesis, sorry. So tumor is tumoro, and then genesis, beginning or starting, like Genesis in scripture or whatever you would say. So I found a document that's also in here, a study that they did with gliomas, and they found that gliomas have stem cells, and that the stem cells are sensitive, I think is the same word they use there, to cannabinoid-based treatment. So the stem cells themselves, sorry, I'm trying to get that out, have CB1 receptors on them. And again, CB1 receptors, when they're activated by anandamide or exogenous THC, are going to induce apoptosis and autophagy. And if you could just induce autophagy, apoptosis is inevitable. If you could just induce apoptosis, then autophagy doesn't matter. I mean, it'll eventually happen itself, but you can't do one without the other. They're both there. So if they're able to target stem cells, this is where the patent comes in and talking about preventative measures. So you can prevent the formation of tumors by being on a cannabinoid-based cancer care therapy protocol, regimen, whatever the doctors would call it. And so to be able to, like, for a special population, what they would call it, or what would they say, special population, or something demographic, whatever word they would use there, for like cancer syndromes, for sure, that would be the number one thing to do. So the cancer syndromes would be where they would start at to be able to start testing and doing some sort of preventative measure for cancer patients. Because if you can keep stem cells from forming, you're never going to get cancer. If you can keep, if you can keep them, I'll say that. If you can't control them completely, then you may. I don't want to make an emphatic statement, but if you truly can treat them with this, then you would never have to worry about any kind of tumor formation. You wouldn't have to worry about anything if something came up that it would proliferate. You wouldn't have to worry about angiogenesis, blood vessels that would feed the tumor. You wouldn't have to worry about the cells not dying but just continually replicating, so you wouldn't have to induce apoptosis. If you do all that, metastasis over the whole body wouldn't happen, because there would be no adhesion, there'd be no invasion, there'd be no migration. It would protect all the healthy cells, so you wouldn't mess up the rest of your body when you're trying to treat it. And it would inhibit, again, down there at the bottom. It would stop it from forming in the first place. Anyway, I want to get up top right. If you go to thewholecancer.gov, go to cannabinoids again. As you scroll down after anti-tumor effects, it starts getting into other types of effects, as well as palliative services that we all know about, like the they say anti-emetic, but anti-vomiting, anti-nausea, anti-pain, all those different things are mentioned on cancer.gov just below this. So the ones on the right and the bottom one on the left, all of that is in the medical literature, and I have it all in this presentation and other videos that I'll make. So along with the diagnosis and receiving a diagnosis, like what happens there on the top left, they got to consider cost, all this kind of stuff. Well, now you got to consider the anxiety, the insomnia, the depression, the nausea that comes from the treatments, the standardized treatments. Even thinking about getting standardized treatments bring anxiety and anxiety and depression, and probably nausea. So, and also the pain isn't from the tumor itself. The pain comes whenever the tumors are getting large and as they grow, they're pushing on other organs, and as they push on other organs, that's whenever it starts getting painful. So even here, I take it right back over to the bottom left, that we can stop them from growing, we can treat them so that they shrink, and we can keep them from forming in the first place. If we can include cannabinoid-based therapy, there's no money in it. That's the problem. And I don't know, there's got to be some sort of way to be able to make it to where it can be financially lucrative, and also for the companies, but also not over too much with the costs. I mean, if insurance companies will cover it, then that'd be awesome. Just let them run the whole thing. Well, I don't want to say that. So anyway, getting back to this over here, I'm just having a conversation with y'all, thinking things through out loud. This is the first time I've walked through this as far as trying to have a conversation about it. I've made it, but I haven't talked through it. So yeah, like I said, the diagnosis alone will bring these types of symptoms. Cannabis treats these types of symptoms. Then down on the far right, or the bottom right, it's not really far, these are the things that you would avoid not just avoid by what's above you as far as the anxiety and depression, and what's on the left there, the necessary access to healthcare and the quality of life and the quantity of medicine. All of that leads down to the bottom right, that you would avoid the cell toxicity from chemotherapy, because the chemotherapy isn't just damaging your cancer cells, and everybody knows that it's a poison. It kills all the other, or it damages all the other cells as well. And there are points where I believe, and many others believe, and I'm sure we can find it in the literature, and I've actually seen articles on it that they've done in the UK following this up with breast cancer patients, so I'd have to just do the research and find it again. But that in some late stages, and even in some like mid-stage, that it's the chemotherapy that kills the person, not the cancer. So the cancer doesn't kill you until it metastasizes into organs that, like your lungs, then you can't breathe, or your brain, and then it starts screwing with your physiological functions in your body. That's what kills you. And so if you're getting chemotherapy and you die early within the chemotherapy treatment, that shows the poisoning is what killed you, not the cancer. So there are studies on this. There are doctors that do agree with this. But it's very controversial because, of course, you don't want to tell people that. That's not something you want out there in the ether, so to say. But yes, so if you can reduce cell toxicity by reducing the amount of chemotherapy you have, by reducing the size of the tumor, and also utilizing it with temozolomide, at least in brain tumors that they found that it works synergistically with, then why wouldn't we do all this? You can avoid the toxicity in the rest of your cells and all of that without having to maybe even start chemotherapy. So this is one thing that I say, is that this is why I push cannabis-based medicine, is because it needs to be frontline therapy. Now, they can dose it however they want to. They can keep it non-psychoactive. They can do whatever they need to. But as soon as they know that somebody has a tumor or any type of cancer cells like leukemia or lymphoma, those types of things, they need to start them on cannabinoid-based therapy. Definitely CBD. You can incorporate THC. THC is no different as far as, it's different. I have been on Marinol, which is THC, and I've been on pain pills. I've been on morphine. All of this, of course, legally through the hospital whenever I came out of surgery. I do not like the high from the oxycodones and all those different oxy ones and hydros. Those got me higher than any cannabis strain, and it messed me up as far as just makes you feel weird. And so we know that THC is the painkiller. CBD helps because it reduces inflammation, which relieves pain as well. But THC is the actual one that reduces the pain threshold, or more like increases. So we need to be able to start implementing these things right away, because why wouldn't we want them to start preventing adhesion and migration and metastasis? Why wouldn't we want to stop stem cells from just getting deeper and deeper? Why wouldn't we want to stop the proliferation? And why wouldn't we want to address the anxiety and depression that comes up immediately with cancer diagnoses? And why wouldn't we want to, again, not want to avoid cell toxicity and radiation exposure and burns, because whenever one of the things, okay, this is one thing that whenever you get radiation, the radiation doesn't just touch the tumor and bounce back up or stop there. It keeps going. So like the radiation that I had on my brain, I have patches of hair, and you can actually see kind of the lines where the radiation beams were placed, and they don't just stop there. I have bald spots on the other side of my head from the radiation being put through one side of my head. So it went through there, and it hits other spots. And so that same thing happens within, like if a woman has ovarian cancer, they push it through there, they're hitting her intestines, they're hitting everything else as they push that radiation through there. And depending upon how far up, if you got ovarian cancer, you can have different organs, the upper part of your colon and maybe the lower part of your kidneys. I have to take a good look at the anatomy features again, but I'm just saying, like, it hits other organs. That's the point. They can beam it in, but the beam still goes all the way through. So I know, that's why they can make it lighter, like a not so intense beam, so it doesn't push all the way through. I mean, it's like any type of radioactivity thing. You can make the beam stronger, you can make it weaker, they can project it in certain directions and keep it away from certain regions, which is what they did with mine as well. He blasted me, essentially. He told me he wasn't going to be able to give me any more after the first session first rounds of it, because of neurological necrosis. So anyway, I don't want to get into that. So let's see. Yeah, I've already said the radiation exposure and the burns from that. There's organ failure involved. You can damage your kidneys and your liver. There is also, I've seen where you can tear tissues, so the lining of your stomach, the lining of the intestines can tear, just by daily walking and moving, or maybe not daily walking, but if like you were to trip and fall or have to stretch your body real quick, or your abdomen, you could probably and easily tear any type of weakened muscle by chemotherapy. And then, of course, like I said, the organs can fail as well. Just the toxicity goes back to the cell toxicity. But the chemotherapy weakens cells and tissues. That's why your skin gets thinner and you bruise easier. And the reason you're vomiting and throwing up is because your stomach lining is the fast-producing cell line. And it also, just not that, but the whole idea of the toxic compounds in your body. The body itself is trying to reject those, and it's trying to reject them through the stomach, but it's not in the stomach, so you end up just throwing up. I threw up bile, so it went all the way down, and I was throwing up highlighter color, like bile. So it wasn't the deep dark green. That came out, but then it turned highlighter. So anyway, as far as the surgery and scarring, pharmaceuticals with side effects, I went over that with the quality of medicine, or the quantity of medicine, the quality of life. So coming back to this, like, if they would have been able to treat the tumor without having to take the big measures to scoop the brain out, or just take that ice cream scoop of that part of the brain out, then I wouldn't probably need as many anti-seizure medications. So it would not only just drop my quantity of medications, but also increase the quality of life. Because I have to be on these medications, I can't just go anywhere and do whatever I want to do. I have to make sure every 12 hours I'm somewhere and I have food in me and all this kind of stuff. So, and then the surgery with the scarring. If you have a smaller tumor, if you have less proliferation, if you don't have angiogenesis already feeding the tumor, then you don't have to worry about such a large surgery. And if you don't have to have such a large surgery, you don't have scarring on the outside, but more importantly, you don't have scar tissue growing on the inside. If you have full abdominal surgeries, or you have brain cancer, or any of these little really sensitive locations in the body, you don't want scar tissue to build up on the inside after surgery. So if everything comes down to limiting the amount. Even if we don't get cannabinoids to be able to fully treat a type of certain cancer, but it has these still effects on it, we can lower the size. Lowering the size, lowering the metastatic potential, and the which would be wrapped around angiogenesis. Lowering those two effects in and of themselves and inducing apoptosis is the gold standard. If we can do that before they actually try and go in and do surgery. Like I was saying, frontline therapy. When I went into the hospital, I spent 2 weeks in there before they ever started doing anything with the brain cancer. And so during those 2 weeks, they should have had me on anti-proliferative medication. They already have Marinol. It's already anti-proliferative. It's THC. And now we got Epidiolex, which is CBD, out there. So these medications already exist. They just got to have people put them together. Like, we don't need to set up clinical trials per se in a lab. If we're gonna, in a extra lab, doctors are already prescribing this at the hospitals. We just need to get specific patients that are going to sign on to some sort of program, and it would be, a clinical trial, but it wouldn't be as odd. Like, basically, you would just be following patients. It'd be like case studies. And you would take specific patients, and depending upon their progression, depending upon, of course, what they need as far as whether or not they qualify for Marinol. Once they qualify for Marinol, you throw them on Marinol and you prescribe them a CBD, a pharmaceutical CBD, and watch those patients at the same progression, the same demographic, same age, same everything, and watch the progression or the dropping of the progression, or the stopping of the progression of the tumors as you're doing it. That's what I'm wanting to encourage, at least right now, within hospitals, because doctors can prescribe Marinol, and we have access to CBD outside of the hospital even. So if they could encourage the patient to get on CBD and to a certain regimented degree, and if they can afford it, then they can get whatever degree or whatever milligrammage they need to have for them to be able to start studying, at least within their medical records of patients, as they try and form these little case studies, or there's another word for it too, concept studies. So we're going to take some concepts, we're going to throw it in some already existing patients that are qualifying for the medications that we would need to be able to even investigate this whole topic, and then we see what happens. That's totally possible right now. You can do that in any hospital. Alright, I'm going to go ahead and cut this off. Let me see how long it's been. It's probably been like 30 minutes. Yep, 32 minutes. Alright. See right here, cannabidiol is a potential anti-cancer drug. And I've already made a video on this one, but as you get down here, this first one is breast cancer. I know you can't really put it there. Cannabidiol, just CBD alone, these are little arrows, so it downregulates, what is that? Yeah, proliferation. It downregulates angiogenesis, invasion. That's the bottom one. It's hard to even read them anyway. So you got breast, I think that one's colon, and leukemia, lung, thyroid. Or no, the one up there is brain. So breast, brain, leukemia, lung, thyroid, and colon. It's just hard to tell. Anyway, you can find that study. I got a video. This one's already has a video. I think it's called, CBD in the treatment of cancer or something like that. But find that. Share these things with people. I know this video was long, but honestly, I love whenever y'all like it, but liking it is only you liking it. And somebody else, I guess, can see that you liked it. But it's not going to go anywhere. I need this, or we need this as a cancer community, patients and physicians and people that are at least advocates in the area of cancer after having, family members or friends or something like that. The whole purpose of this Canna Care project, which is Cannabis in Cancer Care, is for people to know about this. Because if people don't know about it, and we're talking about constituents, then they're not going to talk to their politicians about it. Politicians don't, what they say is that, well, if my constituents aren't talking to me about it, then I'm just going to stick with my constituents, whatever they're talking about. So if that's the case that they're going to take and the stance they're going to take, we're going to have to change the minds of the constituents, which is through education. Nobody, I believe, well, I would say I know that anybody who actually reads this data and understands this data would ever say we don't need clinical trials. If somebody truly understands and sees this data, then they have absolutely no excuse. And I'm not saying they don't have no excuse, rah, rah, rah. But they I don't know, there's no logical reason to see this and then at least work against it. I'll say that. They might not be for it, they might not want to take part in it, and that's okay. I'm not going to down them on that. But there should be some that do, of course. They need to take this up. They have a position of power, and they have a duty to care. Those are legal terms that you can use. And whenever I talk about a legal case brought against a governor or some sort of politician, it would be against their or be negligence because of their lack of duty to care in light of the data they've been given. So it's like a person that didn't trim their tree, and because they didn't trim their tree, somebody got hurt, and that's their negligence. They can be sued for negligence. So if these guys know that damages are going to incur or continue to be incurred by the population, but for or accept that, they vote in favor of this medicine and in this science, I believe that they can be held liable for negligence and damages. That's a totally other topic. I figured I would throw that in there, though. Again, take a screenshot of this and share with people the whole point behind it, that if we incorporate cannabinoid-based care or cannabinoid-based therapy within the cancer community, this is what's possible. We don't have to worry about the cost, access to necessary health care, quantity of medicine, or quality of life. Cannabis can address all of those. And I say cannabinoids because all the constituents of cannabis, there's waxes, there's different things in there that aren't necessarily something we would use in medicine. But cannabinoids themselves, terpenes, flavonoids, all those different types of compounds that are physiologically active, all of those is what I'm talking about. And so if we can do all of these treatments, this perfect list on the bottom left of what an oncologist would say, this is the perfect thing we could ever do. What I want to do is actually go to a doctor and tell them this is some sort of other name, like call it something else, and then tell them, oh, this is something I found, and they're going to be like, this is amazing, and automatically they would agree that this is what we need, period. And then if you bring up cannabis, they're going to be like, oh, well, wait, I don't know if this is all going to happen. I understand that it hasn't been done in people, but I also understand, and people need to understand, that it's not about necessarily genetic expression unless it's genetic expression to the cannabinoid receptors, amount of receptors that are expressed on the cells. Because from what we have found and everything I've read, it's all about the receptors. You activate the receptor, it's a plug and play. So it's a key and lock. That's how it's been described. So as soon as the receptor is activated, it causes a whole cascade of chemicals inside the cell that lead to autophagy, which leads to apoptosis. And if we can find that happening in all these different cancer cells based on the cannabinoid receptors, not personal genetics of each individual patient, well, there's going to be definitely that factor. Then we can really, essentially, if you look up the definition of treat, and according to the 507 patent, cannabis or cannabinoids can be used to treat neoplasia, and neoplasia is cancer, then yeah, we can treat cancer with cannabinoids, and we can cure. If you look at the definition for cure, it's reverse. Technically, a cancer patient is deemed cure after 5 years without 5 years in remission without recurrence. And so they told me I was cured 5 years afterwards. If we can use this cannabinoid-based therapy to do the exact same thing with all this butcher, poisoning, and burning they're doing to patients, then there's no problem. We can say cannabis cures cancer. Cannabinoids cure cancer. And there wouldn't be an issue with that. But I understand right now, without clinical trials, we can't say that. And we need to be able to know that it's not going to be able to treat every single type of cancer. I don't want to say that either. But if it's based on receptors, and we can attach these cannabinoids or any kind of agonist, any kind of activator for those receptors, and they're going to do the same thing in every cell, and they only work in the transformed cells, not the regular cells, non-transformed cells, then yeah, this is like the cure for cancer. It's the closest thing that we can get according to the data. If you look at what's in front of you right there, there's nothing closer than cannabis. There's nothing that comes close to treating all of this stuff with a single set of compounds from a single source. There's no money to be made in it except for farming. GW Pharmaceuticals is a company that's based on cannabis-based care, cannabinoid-based care. They're the ones that manufacture Epidiolex, which is being prescribed here in the United States. It's FDA approved, and that they're growing it in the UK. They're shipping it over here, and we're using it, yet we say cannabis compounds have no medical value. It's primarily for seizure patients, and they say that it's only for 2 conditions with seizure patients instead of allowing all seizure syndromes, or not seizure syndromes, epileptic conditions be allowed to be treated by CBD. This is all super, super corrupt. And it's not just like we're sitting here running down the road tie-dye. It's corrupt. It's corrupt. Like, it legitimately is corrupt. And I'm making another video later on just the conspiracy. There's conspiracy theories, but then there's true conspiracies. And we're going to take a look at the conspiracy between the Department of Health and Human Services, the Patent and Trademark Office, the DEA, and there's another one up in there too. Oh, the HHS. I think I already said that. Health and Human Services, yes. And there's a few more as far as private companies. But this is going to be a no-cut video. Definitely not going to run back through this. Anyway, I'm going to go ahead and get up off of here. Get up off of this. Because I'm chilling in the car where it's nice and quiet and cool. Use it like a studio. And all that jazz. So anyway, love y'all. Any questions, bring it. Any doctors want to talk, send them my way. I want to talk to everybody. I want to inform everybody. I want to spend time with people, cancer patients, doctors, anything. This is my labor of love. This is my commitment right now, at least as far as like some sort of time. Jesus and people and discipleship is number one. But as far as what I do throughout the day, time-wise, or what I have time for, I should say, is this. So, this is the direction I'm going. I want other people to go, not because of me, not because I'm cool or I got better data than them, but because this truly is a region to go into. We're all about, cancer walks and marches and things like that, and wearing the pink and all that kind of stuff. And people are like throwing money down on it and all that. But this is where to throw money down on. We need money in this. And I'm pushing to make sure that UT can in some way influence the politicians, not like in a shady way, but like basically, what would it be, I guess, push on or nudge the politicians to allow them to practice their own medicine, to do their own research, to set up and design their own clinical trials instead of having restrictions placed on them by career politicians. These guys are not our friends. A lot of times. Many of them are. They're solid people, but there are other people that meet with parents who have children who are going through crazy stuff, and then these people turn around and vote against their interest. And that's not cool at all. But there are some really, really good politicians and legislators out there that are fighting on behalf of people, on behalf of patients, and they're siding with the evidence and the data. They're not against the science. And others are against all of this, is what we've talked about. They wouldn't give me time to talk about any of this. I wouldn't expect them to give me this much time, but any of these other things, they take 4 minutes. Right there is the chemotherapy and radiation, anti-cancer mechanisms of cannabinoids. Like, this is what we know. They say, oh, we don't have enough evidence. What is their criteria? Where is their canon? What's their ruler? We don't have enough evidence. What is enough? What's your definition of enough? You say enough, you got a specific thing set in your mind where there's going to be a bar of not enough and enough. Just by saying there's not enough, by default, you're saying there is enough. So how much is enough? Now I'm just talking. Anyway, I'll let y'all go. This is a woman that she was 29. I think I was 28 or 27 when she did this. She had GBM, and she did a death with dignity. She went up to Oregon because she was progressing with her GBM, and she basically committed suicide in order to not have to go through what GBM eventually does through its progression. This right here is, you can read this, just take a screenshot or something, but this is a child whose parents treated him with cannabis oil. He had a brain cancer. I don't remember how old he was. This was over a 16-month time period, had a 95% regression, and they just put cannabis oil on his pacifier, I think 3 times a day. So this is what's possible. This isn't going to be the standard every time. I'm not going to say it is, even though I do think it will be or can be in the future. As we start mixing different types of cannabinoids and using synergistic therapy and applying that also conjunctively with traditional chemotherapy and radiation. But I believe this is what's possible. And if it's what's possible, then why wouldn't we do this? Love y'all. Peace.